of the diagnostic stuff I've been going through, and what makes the difference is someone who listens and who goes, I believe you. Because very often clinicians are like, are you sure that's your symptom? Are you sure it's not this instead? And actually having a doctor sit down or a physio and say, I believe you and I believe that this is not just in your head, is one of the most amazing gifts you can give to somebody.
Connective tissue disorders such as Ehlers-Danlos Syndrome, EDS, are diagnoses that individuals and healthcare professionals are becoming much more aware of in clinical practice. As healthcare professionals, it's important not only that we're aware of these conditions from a physiological and diagnostic perspective, but also that we understand how these conditions affect our patients on a functional and individual basis. Today I'm joined by Ellie Ovens, who is a disability advocate and has a diagnosis of both EDS and postural tachycardia syndrome, or POTS. Today we'll be exploring not only what these diagnoses are and how to manage them, but also how they impact on patients' lives and what we can do as healthcare professionals to improve our management of patients with chronic health conditions. So, Ellie, thank you for joining us today.
For having me. It's really exciting.
No worries. So today we're obviously going to be covering quite a lot of ground, looking at a few different topics. And one of the primary areas we're obviously going to focus on is Ehlers-Danlos Syndrome, or EDS. And what I want to explore with you today is not only what EDS is, but also how it impacts you on a day-to-day basis and what we can do as healthcare professionals to make that journey through the healthcare system better for people who have chronic health conditions. I suppose the obvious place to start is what is EDS? What does the textbook tell us it is, and how is it defined?
So EDS is a health condition which is defined as the misformation of collagen within the connective tissue of the body. It comes in many different forms. I think currently there are 13 classifications, and they go from things like vascular EDS, which is quite rare, but also much more dangerous. And the most common diagnosis at this moment in time with the genetics we currently have access to is hypermobility type EDS, or hEDS. And that is a tested, like a physical assessment diagnosis. There is no genetic testing at the moment for hEDS, so it's kind of partially dispensation diagnosis, so kind of once you've discounted everything else and what you're left with, and it's also partially on physical exam and seeing what your body is like and your range of symptoms.
So it's something that can have an impact on many different systems. Then you're talking vascular, connective tissue, it can affect you in lots of different ways then.
So being genetic, and I'm going to go slightly into kind of gene theory at the moment, just because that's what you end up in with EDS, is that so in the same way that your body, the skin on the palms of your hands and the skin on the backs of your hands is very different because your body is expressing different genes. The same thing happens with the genes that are dealing with your connective tissue. So just because someone has EDS, it doesn't mean that they will all look the same. And it can affect every area of the body. It affects your joints and dislocations, which as physios is what you're probably going to see most likely. Unusual back injuries, shoulders, knees, hips, someone dislocated something that you're like, I didn't even know you could do that. Quite common in our community, but also it affects breathing, it affects respiratory function, cardiovascular function, diet, and like digestive systems are a really big one in EDS. Quite a lot of people end up with respiratory physio, or they end up being tube fed because the muscles around their stomach stop contracting correctly to enable them to digest food on their own. So it's a really wide-ranging condition, and it goes from someone that doesn't even know they have it, they just look a little bit bendy, all the way up to people who, like I said, are on breathing tubes and feeding tubes because their system cannot support itself anymore. So yeah, it's a complex cloud of information, and we'll link some extra resources from EDS UK in the description box for a better understanding of all the different types.
Fantastic. Yeah, and I think that's really important, obviously, from a medical perspective, because you're saying about, dislocations that you didn't think were possible or whatever. And I think it's your differential diagnosis, knowing there's that background there, or having that on your radar that there could be that background, because you might think, well, with that mechanism, you shouldn't have dislocated it, you shouldn't have had this go on. But obviously, if there's that background there, then that could be the reason why that's happened.
Dislocated my entire ulna by using a mouse pad on a computer, and the whole thing came out. And when the physio put it back in, she went, "I didn't know you could do that with an ulna."
Absolutely, yeah. So, so you mentioned, just to touch on this briefly, then you mentioned about it being genetic linked and things like that. So, is EDS something that generally we're born with? It's not something that could develop or be expressed over time. It's something that you're born with EDS, but you may not be diagnosed till later. Is that correct?
Yeah. So, EDS being, as far as we understand it, genetic, you are born with it. I will say that the hormone changes in people's lives impact how much those genes are expressed, and also change how many symptoms they can be having. So quite commonly, you will see people suddenly become more symptomatic at times when we know that there's massive hormone changes. So puberty, mid-20s and menopause for women are really big. And then early 20s for blokes and like late teens are all big times that we start to see people suddenly go, "Oh, I was coping okay, and now I'm not." And it's because of hormone fluctuations in your body and how they impact your connective tissue.
Absolutely, yeah. So again, it's looking at the person holistically, that clinical picture of where they're at in their life and what's going on at that point in time. Fantastic. So you mentioned briefly diagnosis then. So how is EDS diagnosed then? If it's suspected, or let's say somebody comes to a physio clinic and we think, okay, there's a few things here that might lean us towards that direction. What's the pathway for diagnosis? Is it through a GP or?
The pathway for diagnosis currently is really challenging. For formal diagnosis, you need a rheumatologist to diagnose that. And getting through to them is really difficult. Lots of people who have suspected EDS currently have diagnosis of things like fibromyalgia or ME, because trying to fight for that diagnosis, if you have it in a family and you can see that it's in the family, you're more likely to get a diagnosis more quickly. But it's a real challenge, and it's something that the EDS community is fighting for all the time to make that easier. For a physio, if you're seeing someone who doesn't know and they come in, I once had another physio explain to me that at the point that you get given your little human body to colour in and someone's come in because they've tweaked their ankle, if you then talk to them and you start colouring in the rest of their body, then you've probably got EDS going on. Because at the point that you've now got an ankle and a knee and a hip and a shoulder and an elbow and a neck, those sorts of things, once you end up with multiple issues all happening at the same time, quite commonly that's going to steer you in the direction of something that is slightly harder to diagnose and more like EDS. The diagnosis used to use something called the Beighton scale, which is a scale of hypermobility. I don't know if you guys have seen that before or use it. That is no longer a diagnosable criteria because medicine now understands that you don't have to meet the Beighton scale criteria to get diagnosis. I will also say that lots of clinicians will now support EDS without a formal diagnosis because it is becoming more understood.
Mm-hmm. Yeah, and I think the Beighton scale is something that we have used traditionally for a lot of things, but you're saying that you can have EDS without scoring high on the Beighton scale as well, which confounds things. And I think it's really, without wanting to sort of jump the gun for some of the other things we're going to discuss, obviously you've said about, you come in and it's the ankle, but it's also the neck and the shoulder and the hip and everything else. And I think there's two layers to that. Firstly, there's the fact that, if you come in for a physio consult, maybe you only have 20 minutes. And so how easy is it for those things to get missed? I've rolled my ankle. Okay, let's talk about your ankle. And we may not even get to explore these other things. But I imagine the other thing as well is once patients, and from being a clinician as well, once patients come in and they start colouring all these other areas in straight away, your radar is going down the route of EDS, fibromyalgia, ME, chronic pain, all those different things. And it's very easy for people to get put into a box, isn't it then? Yeah. And I imagine there's a certain amount of stigma that potentially goes with that of, here we go, somebody else, widespread pain, you know, we put you in that box and send you along the line without unpacking it.
Yes, exactly. Yeah. And that's really common. I will say that. So I'm now in my 30s. I wasn't diagnosed until I was 27. My mum has the same condition because it runs in our family. She wasn't diagnosed until she was 58. So you're looking at an average diagnosis time for people living with this condition, which causes, as you say, complex regional pain, complex overall pain, fibromyalgia symptoms, fatigue, all of these other things. And you're looking at an average diagnosis of about 30 years from onset of symptoms to when people actually get given an answer.
Yeah, which is a really long time when you think about how, as an individual, you have to adapt your life around that condition, potentially being told, oh, it's in your head, or it's, you know, being played down, belittled or whatever. And it's actually that there's things that can be done to make your life so much easier with that diagnosis. Totally. And so yes, obviously you go to your GP, you've been referred to a rheumatologist, you wait to see the rheumatologist, and then the rheumatologist will be the one that needs to put that diagnostic label on there then of EDS.
And normally while that's happening, because that can take years, you will end up seeing a physio at some point in time. And so you guys, like the most common people that people with EDS end up going to see are the physios. So you guys really are on the front line of working with this condition.
Absolutely, yeah. And so when you go to the rheumatologist, then bloods, I imagine, are being done for a lot of people, or what kind of tests are they using?
So they're using bloods to screen out for things like lupus is a common one, Lyme's is the one that they often test for, because they're trying to exclude the things that, you know, really need hardcore medication management. And then it's a case of, you know, it is literally a conversation. It's a conversation about symptoms. It's a conversation about does someone else in your family have similar symptoms to you? Because if they do, that makes it more likely they will listen to your heart to see if you've got a heart murmur, because that can come as a side effect of certain types of EDS. Do you get lots of migraines as a symptom that comes with EDS? So you have an in-depth conversation, and it really is like trying to put puzzle pieces together. And there is no kind of, apart from exclusionary testing, you might have ultrasound scans done to see if they can see any deformation in things like blood vessels, or they can like see what your digestive tract is up to, because that gives them more clear indicators. But yet normally it is just which symptoms do you have, and do you have any of the comorbidities that normally come along with EDS? And that is how you get the diagnosis.
Yeah, so primarily, like you say, it is that diagnosis of exclusion, and therefore, obviously, it's so dependent upon the people that you meet along the way as to how quickly you get to that point as you go down that journey. Great. Okay, so I suppose that leads us nicely to management then. So how is EDS managed? You know, you've got these signs and symptoms of things. You get your diagnosis. What then happens from if we look first at a medical perspective, and then maybe from a rehabilitation perspective? What would the rheumatologist do?
So the first thing you get is you get a nice letter that says you have EDS, and then that normally, apart from kind of onward referrals, so because EDS is a multi-systemic condition, you'll be sent off to go and see a gastroenterologist and a cardiologist and respiratory and all these different people, but it's mostly symptom management. Or rather, it is all symptom management. There is no cure and there is no easy pill. And actually, one of the most important parts of managing EDS is physio and activity, specifically controlled activity, to help with managing the symptoms. And you can manage some of the comorbidities through that as well. You'll often also get braces to try and support your joints. But again, those need to be used carefully, because if you get muscle wastage, that makes symptoms worse. So I'd really love to say that they give you a nice tablet and then all your symptoms go away. But unfortunately, it is very much more lifestyle management. And as you were saying, kind of rehabilitation style management that kind of controls the symptoms as much as possible.
And can I ask then, is pain a big issue for people with EDS? Is that something that needs to be well controlled as well? Because obviously if you're looking at long-term pain management, thinking about what you're taking for pain is obviously then quite important, because it's not just 6 weeks it'll be fine, a lifelong thing.
Exactly.
So is that something then as well that's...
It really is. Pain management is something that's a real challenge because it covers your whole body. At the extreme end of the spectrum, I have friends who are taking like fentanyl 3 times a day just to control the level of pain they're in. One specific friend has a full spinal fusion just to control her spine and her pain levels with fentanyl. And so trying to manage pain and most of us, I will say most people do not want to end up on pain meds. We know what the risks are, we know what the side effects are, and it's not something that people jump for joy when they get told that they need them. But at the same time, once you've gone through all of the other things you can do, then long-term pain management, depending on what sort of pain it is, and depending on what your body tolerates, because the other issue is that not all, so EDS is contraindicated with some pain medications. So actually some pain medications can cause more regional pain, which is a challenge of its own, and it's not something that I'm well enough versed in to go into here, but you can definitely look it up. So I mean, neurological painkillers are something that are very common in the community, and then high doses of analgesics and of NSAIDs, if you tolerate NSAIDs, is kind of the way to go on that, just to keep functionality and mobility going.
And I suppose that's the question, and with you saying about NSAIDs as well, is there an inflammatory component to this? Do we know, is that part of the physiological process as well?
Well, so the inflammatory process in EDS comes from, if you think about it, all your joints are moving too far all the time, all your ligaments being pulled and stretched and squished. And so injuries are super duper easy. If you think about it, if you stretch a muscle so that the fibers are barely hanging on and then you load it, those fibers start to peel apart. And so you can end up with semi-tears and things, and that causes a lot of inflammation. And the other thing I will also say is, very random thing in EDS is that they've discovered that the nerve pathways in EDS that you will have looked at uni do not align in people with EDS. So all of their nerve pathways are slightly off. And so that makes managing pain even harder, because you can't necessarily tell where it's coming from in the body or where that signal is coming or going from, which is really interesting. But there's a lot of inflammation involved. Trying to calm down the inflammatory system as your body is just being stressed all the time is really important. So that's the reason that NSAIDs are quite often used.
Yeah, because obviously that comes with its own baggage. I know all medication does, but then the effects on I'm just thinking that the gastric effects of EDS, to then add anti-inflammatories onto that, to then start thinking about antacids and stuff. So, it really is that holistic sort of package. And obviously we talk a lot about the biopsychosocial model and how important it is to look at a person as a whole, but obviously that can be really challenging within the confines of what we've got available to us. So I suppose what would perhaps be great now then, perhaps if you could talk a bit more towards your experience and your journey, and we unpack that a little bit, because as you say, it's something that you weren't diagnosed until relatively recently. What was your pathway through the healthcare system with this?
So my pathway was that, I started I was a child who was always flexible. I was always tired. I always struggled with digestive issues, and with things like I couldn't gain weight. And as I became a teenager and became older, as my hormones changed, I went through periods of time when I just physically couldn't walk, or I just couldn't move. I was bedbound on multiple occasions through my adolescence. I managed to get through school with support. I managed to get through uni. And then it was when I went out into the world of full-time work that, unfortunately, I trained to be a nanny, and that is a very intense physical job. And I was working 16 hours a day, like 5-6 days a week, most often. And my body just completely dissolved on me. And at that point, I ended up being in need of full-time care, and my parents took on that role for me. And it was through their persistence and us going back to the doctors again and again that the doctors started to send me off to go and see consultants. And actually, it was my cardiologist who I went to see for POTS, which is a comorbidity, so postural orthostatic tachycardia syndrome, who then looked at me and said, no, I think you've got EDS. And so sent me onwards from there. But yeah, I mean, it took over 18 months from the point that a consultant told me I probably had EDS. It took me over 18 months to get another consultant to agree to that diagnosis, which at the time was a really long time. Now, I would consider that short. Now you're looking at more like 3 years in that gap.
So it's not even just it's got to be proposed; it's got to be agreed upon by another consultant in order to get that diagnosis, which obviously, like you say, it's not just getting to that point of we think it's EDS; it's getting to that point to then confirm that, which is crazy. And so I suppose in the meantime, then, are you happy to share, what were you sort of diagnosed with then before getting to that point?
Yeah. So my full list of diagnoses runs, formal diagnoses runs to 27. And so I have a couple of other health conditions that quite often come along with EDS. So mast cell activation syndrome is one that is very difficult to manage and is something that's quite challenging to physios. But I think that's possibly a different podcast episode, if I'm honest, Alex. And then I have my most fancy title is I have something called idiopathic multisystemic dysautonomia, which you can have fun trying to break that down, but basically medical term for nothing in your body that should work on its own works on its own, and we have no idea why. And so you kind of, they can't, anything that your body would do on its own, blood pressure doesn't do, digestion doesn't do, breathing, not really a fan of that either. So all of them have all had to be maintained medically for me over the years. But yeah, all of those things coming together mean that someone looks at me and goes, oh yeah, you definitely have EDS.
So those things are still relevant. So that it was almost like ticking off, okay, we've got POTS, we've got the this, that and the other, and then it's come together to say, right, well, the root cause, so to speak, is the EDS. That's what's causing all these different things to happen. But then it sounds as though without that piece of the puzzle, it makes understanding and managing everything else so much harder because of understanding, knowing the physiology of how EDS works. Is that fair?
Yeah, completely. Having the ability to say to a doctor, I have EDS, means that they have, a label, as I like to say, is a shorthand for a lot of information, and EDS gives them a full drop-down menu of all the other stuff that can come along with that. So when they look at me, and I don't know whether you guys still teach this, but I know that lots of doctors and medical practitioners are taught, hear hooves, think horses, not zebras, which is the reason that EDS has the logo of a zebra, because we are the anomalous animal. And so, it gives the doctors the opportunity to go, okay, we're already dealing with a zebra. Let's look at the unusual things that can go wrong.
Absolutely. No, that's great, because that is something that, that's 101 teaching. If it looks like a duck, walks like a duck, sounds like a duck, it probably is a duck.
In which case it's a duck-billed platypus.
So that's really powerful, because it's looking at, it's not just how we manage your symptoms now in the moment. It's looking at, well, what other things do we need to be aware of? And we always talk in healthcare about this, an index of suspicion, So for example, there's a lot of really nasty things that can come along and afflict people. But we know that on the whole, they're generally really rare. So, the risk of it being something really nasty, life-threatening, that we need to urgently investigate, although the stakes are quite high, it's relatively low probability that it is that, and we obviously need to be thorough and make sure it's not. But if we know that background, then we know that we need to be much more on it in terms of, okay, these are some other things that we need to be wary of. And I think even just talking really basically from a physiotherapy perspective, dislocation is up there, isn't it? Obviously, as a big thing, and the trauma associated with that, of like, well, you're a young, healthy 20, 30-year-old, that shouldn't have caused a dislocation, but in actual fact, with your background, perhaps it could have done.
Yes, exactly. That's really common.
Fantastic. So your experience, then, it sounds like there was a lot of pushing on your part to get that diagnosis, and if you hadn't have pushed that still may not have got to that point. Is that fair to say?
Yeah, completely fair to say. It's really common. Unfortunately, post-COVID, it's also much more difficult. I will also say that the consultants that lead the teams that specialise in EDS, this is their area of passion. And so at the point that some of those clinicians retire, it doesn't necessarily mean that that clinic will carry on seeing EDS patients. And so that's quite common, that people end up under clinics that no longer want to see them because it's not their area of passion anymore, which makes it even more challenging.
And so, I mean, what would your advice be? Because I know I've dealt with patients in the past, and we spoke a little bit about this off air, who, you know, you have a suspicion there may be something underlying here, and it may not be, you know, they're presenting with all the, you know, the really serious forms of EDS, but, you know, you think you've had quite a few ligament injuries, you've got multi sites of pain, this, that, and the other. Yeah. Do you feel for most people it is really worth pursuing that diagnosis? Because I know some people will say, I haven't got time for that, it's another label, it's no use to me. What would be your thoughts around that?
So I think it depends on the impact on someone's life. If someone is managing well and they are getting the occasional injury that they're then seeing a physio to help manage, then I think as long as they are happy and comfortable and confident in their life, it is not going to be a priority for them. At the point that you've got multiple things going on and you are struggling to get answers and you're struggling to be taken seriously by the health care community, I would then be saying to go and look at EDS UK and the information that they have that you can take to your GP with you to show them this stuff. And then that is the beginning of your pathway to diagnosis. And again, that is a long pathway. So management of symptoms during that period of time is really important. But yeah, if you have lots of things going on in a patient's body, and as you're talking to them through an appointment, they're telling you that, you know, it's not just joints and ligaments, but it's other things. And, you know, they get heart palpitations or chest pain or stuff like that. Those are all EDS symptoms. And so, you know, once we've ruled out things like heart attack or things like that, then we look at EDS in hopes that they will get a better quality of life out of a diagnosis and the support they can receive.
Yeah. Brilliant. Thank you, Ellie. So I think you've given us a really fantastic overview of what EDS is, and also how it affects people on an individual and a personal basis. So what I want to do now is move to look through a bit more of a healthcare lens. So you've obviously seen lots and lots of different clinicians, different professionals, and I imagine you've seen some who were really helpful, had some really productive interactions, and others that were perhaps less so. So I've obviously got my feet in both camps, being a clinician and a lecturer. So, you know, we're always looking to teach best practice, clinical guidelines, biopsychosocial management, but I'm also fully aware of the challenges of 20-minute appointments, back-to-back patients, you know, the fatigue at the end of the day, and that feeling you get when, you know, your patient comes in and they do start circling all those different areas on the body chart and thinking, oh, where are we going to go with this with the time we've got? So what I was wondering if you could perhaps talk a little bit more about some of the interactions you've had, the people you've met on your journey who, you know, you've had some really positive interactions with, and what made them positive, what made them really helpful to you.
Yeah, so I've had some amazing clinicians over the years that I've been going through all of the diagnostic stuff I've been going through, and what makes the difference is someone who listens and who goes, I believe you. Because very often clinicians are like, are you sure that's your symptom? Are you sure it's not this instead? And actually having a doctor sit down or a physio and say, I believe you and I believe that this is not just in your head, is one of the most amazing gifts you can give to somebody. Listening to them, even if that's most of the appointment and you only have 10 minutes at the end to go, okay, thank you for all that information, I completely understand, we're going to book another appointment, you're not going to see me for another few months, but I'd like to take that time to look at a plan for you where we can start to like work on this. I might be able to give you some exercises on the little bit of your body that you came in with originally, but thank you for letting me know. And that is just, I've never come out of an appointment wanting to skip so much the first time the clinician said that to me, which is ironic because I was in a wheelchair when I went to that appointment. But yeah, just that gift. And yeah, Dr. Nick Gould, who's my cardiologist, always willing to give him a shout out. He's absolutely fab. The other thing he does, and I think this is a real trick, is that when you go back into his appointment next time, he will read you his last letter. And he does it in a kind of, I'm just double checking this is where we got up to. And it's totally his way of re-remembering who you are, which means that instead of you waiting outside while he sits there and rereads all your notes, you're already in the room and he's rereading all your notes to you to confirm that he's got all the information correct. And it also reminds him who the heck you are out of his 800 million patients. So, I think that's quite a nice trick, because it means that even in that 20-minute appointment, instead of going, I've got to do 5 minutes before the patient comes in of just reading their notes, they're already in the room with you and they can feel that time. And it makes, because quite often, I mean, bad clinicians, I've been in appointments for less than 3 minutes, where a clinician comes in, they tell you something, you're like, that's not even me. Mm-hmm. Can I question that? And they're like, no, it's definitely you. Here's the thing, go. And yeah, it's been, I think my personal record is under 3 minutes for getting in and out of a London specialist clinic consultant appointment. And that just, it does make you feel like just another annoyance on the page. And I totally get it from your guys' end. You know, you guys have seen hundreds of patients all day, and you are really tired, and you're also feeling like, oh my goodness, I've got to do my best for everybody. Your patients are aware of this, especially if they have chronic health conditions. You will not be the only clinician they're seeing. And so being really honest with them and being like, yeah, it's been a really long day. You know, crack a ridiculously mediocre joke. We're always open for it. Get your dad jokes out of the cupboard, just to kind of break people into it. And then, yeah, talking to them as if, you know, they're a friend. And even if in the back of your head you're like, is this psychosomatic? Go with, you believe the person, because you'll get a much better working relationship with them from that point.
I think that's so powerful to hear somebody say that as well, because I worked for a long time in chronic pain, and I know that we would have, say, an hour maybe with a patient to assess them. And sometimes it would be 40, 50 minutes of just listening to that person. And I think especially the way we're trained, and especially if you're new to this, we're healthcare professionals, we always want to fix people. We always want to help people. We're like, we need to be doing something. And so to hear you say that actually sometimes the best thing you can do is just listen is, you know, it puts you at ease that that's the right thing to do. It's about reading the person in that situation rather than this is what my job description says I need to do. And obviously we need to, you know, we talk about must, should and could lists. You know, what must I do at the end of this appointment? Well, maybe there are a few questions I need to ask you, but I'm going to let you talk first and do those at the end, perhaps. What I'm hearing is that validation that you're saying, that acceptance of where you are and what you're saying is such a big, important part of building a relationship and trust.
Yeah, absolutely massive. And, you know, as you said, clinicians and doctors, you guys get into this role because you want to help people and you want to heal people. And sometimes actually, and I'm sure you've experienced this, especially in people with chronic pain, listening to them and accepting their reality as their truth is one of the most healing things you can give that person, because you've taken away their self-doubt. Mm-hmm. And that can be so destructive, especially if you're in pain all the time and you're always feeling nauseous. And so, yeah, you know, it feels, sometimes it feels like you're not doing enough, you want to do more, but actually just know that you really are still doing the healthcare role that you're paid for. You're still helping that person on their journey to recovery and healing by listening to them.
Mm-hmm. And I think that's a real nuance that I think is so important for, especially for newer or less experienced practitioners, is the fact that I can accept everything you say as true and that's your experience, but also discern from that what is, say, relevant to my diagnostic procedure. You might have a symptom that doesn't fit, and I might not need to do anything about that, but it doesn't mean it's not there. It doesn't mean you're not experiencing that. It doesn't mean you shouldn't be feeling like that.
Yeah.
And so I think that's a really important point to get, is that it's not about challenging that experience. It's about accepting that that is this person's experience, but it may not match the textbook, and there may be some things you need to go into and some things you don't. I really like your account with your cardiologist as well, where you said about he will, read the letter to you when you come in. And I think, for some people, I can see why they might be like, well, I expect you to know who I am before I come through the door. And I think as healthcare professionals, we think, oh, who is this person? I've seen 10 people already today. Which shoulder were you? Which knee were you? Or whatever. But I think what's nice about that example is it's the accountability, I suppose, that the doctor's given there, because we've all had that experience. We go and see a consultant or a doctor, and then 3 weeks later we get a letter in the post, and you read it, and you're like, I feel a bit misrepresented here. Like, that wasn't how I felt. That wasn't quite what I described. So by doing that, it opens that door to say, well, actually, no, I didn't say that. That's how I was feeling, and that's a really nice way to, again, open that door to a conversation with you about things.
Yeah, exactly. It's great. I've also had clinicians use a dictaphone to actually write me their letter at the end of the session. If it's not going to be a really long letter, just going, I'm going to record this. Let me know if something's gone wrong in this. And they record it and they're like, is there anything I need to adjust in that? And it, again, as you said, it means it saves you getting a letter 3 weeks later thinking, was I in the same appointment as that doctor? Because I think we've all had that experience, even with the GP, where you're like, I thought I was in a completely different appointment to you.
Yeah.
But no, I really like what you're saying.
And I imagine the other thing it gives you is control. You know what I mean? Because you're going to see this person for help, for support, and you're feeling vulnerable enough. You've been told lots of different things by people, and you're at the mercy of this person who you've potentially paid a lot of money to see, or waited a long time to see, and you've got the control to say, no, this is my reality. That's not correct. And I think that accountability is so important, and I suppose even at the other end, the more experienced practitioners, that's where we're more guilty of shoehorning people into a box to make it fit, of like, well, yeah, maybe, but they've got this and this, so they're probably in the chronic pain box, or, moving people into a box to fit what works for them, rather than saying, this doesn't fully add up. Maybe we need to explore a few more things.
Yeah, I mean, one of my diagnoses, 95% of the time, the only people you see it in, which is a form of neuropathy, is people with type 2 diabetes. So if I'm on a phone appointment and I tell someone that I've got neuropathy, this small fibre neuropathy, and I don't specify that it's not related to diabetes, they've just made a judgment about what weight I am, what my diet's like, all of these things that we don't even know we're making those assumptions. And quite often we have to actually notice our own assumptions to be able to challenge them. So as you said, one of my favourite sayings is one size fits none. As soon as we try to stick someone in a box, you're automatically chopping bits off and squishing bits in to try and make it fit in the box you want. And so actually the help comes in boxes, but people don't.
And it's such a hard thing to work with as well, in a way, because one of the main things we teach you at university is to make those connections. So okay, you've got a 30-year-old individual with these comorbidities and this. Paint a picture of that person. What do you think you're going to be looking at? What's your likely diagnosis? And it does work. It works on it in a hypothesis generation. It works in a time-saving manner. And I suppose one thing that's worth adding on here for healthcare professionals is, I would imagine, it's looking at what you can do within the confines of your service. When I was working in FCP and you had 20 minutes, you're not going to be able to fully assess that complex presentation, validate that person, give them a management plan and all those other things in 20 minutes. But you can listen, and you can rebook them, or you can signpost them, or you can go and do some reading or look for advice. And so, because I think that's the other way that people go, is they then end up an hour late for their next patient because they're like, whoa, what do we do here? And that's where, again, another topic, another podcast, but how do we negotiate that? But I think to pull from what you've said there, that validation, that acceptance of where the person is, and rolling with resistance, as they would say in motivational interviewing, and resisting that writing reflex is really important.
No, completely agree. Yeah, and also, we're aware you've got the next patient coming. We don't want to make you late. Actually, quite a lot of people I know, including myself, will turn up. If I go to a new clinician and a new appointment, I know I've got a list. I've got a list of meds that you're going to want, and I've got a list of diagnoses you're going to want. I will just roll in the door and I'll put both of those pieces of paper on your desk with all the information that you need on them and say, that's your copy, you get to keep it. Because I know it saves us time. So if you need to, you can always say to the patient, would you mind writing that down for me and giving it to the receptionist or something like that? If you're like, I want your full meds list, but I can't get it off you right now, that's fine.
Yeah, definitely. So I think you've given us loads of fantastic information there, and I suppose what my question to you now would be then, if you've got a physiotherapy student or a new qualified physio or somebody in a role who wants more information about EDS and managing chronic conditions, complex presentations, things like that, what would be maybe your 3 take-home pieces of advice for that person in terms of helping them to not only do a good job, but make you feel heard and validated?
So, if you're interested in things like EDS, go onto YouTube, type in EDS. There are amazing lectures from consultants and physios all over the world about the health condition. If you have a patient come in with something you've never heard of, YouTube is a great source to go and find out about it. And then if you're meeting a patient for the first time, it doesn't matter if they've got chronic health conditions or they've just hurt their knee on a skiing holiday. Listen, be patient, and try to stay out of judgment, because it's such an easy thing to slip into, but it just doesn't help anybody in that situation. And then you will be grounded for all of the other knowledge that you have added through degrees, through training, through experience to actually be used. So yeah.
And again, it's that thing of, like you say, 3 minutes in a consult and that's it. You never see that person ever again. There's no way through. And I think it is partly, I suppose, knowing what we can do and what we can't help with. But, if you burn that bridge with the patient, they're not coming back. You can't help them when they're not there. So within our scope of practice, we need to be doing that. But even, I think, patients who need signposting and need additional support, they're going to take that from somebody that they trust, that they've built a relationship with. So I think those 3 points are really, really powerful.
If you need to have a conversation, if you need to have a difficult conversation about lifestyle changes that have to be made, about giving stuff up that they don't want to, or that things they're going to struggle with, having that, as you said, having that interaction, having that connection and that understanding that you're a safe person and you're not doing it from a place of judgment, just makes those conversations go even better. And I will also ping Alex the link to a book called Super Communicators, which is about how to get the best out of any form of communication across a massive genre of jobs. But yeah, it's really insightful, and I highly recommend, if you'd like to be able to communicate really effectively with individuals that you don't have any connection with normally, then yeah, it'd be a good place to start.
Fantastic. And I think obviously we'll put the link to that and a few of the other things you've mentioned in the description below. Just to finish then, Ellie, is there anything else you're involved in that you want to share, or any other things you reckon to signpost people towards that might be useful for people who want further information?
Yeah, so I'm part of a fantastic chronic health Pilates community. We're 100% online, and all of our instructors have chronic health conditions of their own, and most of the people that come along have chronic health conditions or are moving into an older stage of life. And so if you need to signpost someone to something that is a community-based activity to help support them, then yeah, Mobilities would be one of my absolute top shouts. You can get it all over the country. We've even had a couple of people join us from other parts of the world. So yeah, that one's good. Otherwise, yeah, just once you get into the YouTube videos of all those sorts of things, you'll find the whole world of random health conditions you didn't know existed. But yeah, no, thank you so much for having me, and it's been great, and I will try to remember to send Alex all the appropriate links.
No, it's been really great to talk to you. Thank you so much for sharing your story with us, Ellie, and coming on today.